the transferrin receptor and to deliver a specific payload to targeted tissues. We're also going to talk today about the DYNE-251 program and show you some long-term safety data as well as real-world functional outcomes. We're also going to talk about the DYNE-101 program for myotonic dystrophy, including the safety profile as well as clinically meaningful improvements seen in various motor as well as CNS manifestation outcomes. So let's begin by where we are currently and what types of unmet needs we are encountering these days. So the delivery of antisense oligonucleotides has been plagued by having insufficient transduction efficiency. And fundamentally, as a community, we suffer from having delayed diagnoses when you compare when our patients' symptoms started and when they actually get diagnosed. This is partly a result of having less disease awareness and connecting symptoms of a patient to a specific neuromuscular entity. And then fundamentally, especially for Duchenne and myotonic dystrophy, we are contending with symptoms manifesting from more than just muscle, and they're often multifactorial, affecting the central nervous system and the heart. And it's been difficult to actually address the different needs of the various other organs, and historically, we've all primarily focused on muscle strength as the primary outcome. And now is perhaps time to actually think about other organs that are just as important and possibly even more important to some patients because of the impact it has on their daily lives. This graphic actually gives you a nice overview of the various platforms that we're able to harness today. And on the left, you'll see our classic antisense oligonucleotides that uses RNA technology, anything from causing alternative splicing to recruiting RNases to actually cleave the mRNA. Then comes the RNA interference, where you actually are able to deliver an siRNA, a small inhibitory RNA that gets recruited to an mRNA, and with the RISC complex, you're able to cleave the mRNA. And then comes the pretty advanced technology in terms of gene therapies. We have everything from being able to replace a gene in its entirety or a modified version of the gene to even using a bacterial enzyme like Cas to allow for a specific particular portion of the gene to be targeted and then possibly even cleaved using a molecular scissor. On the right-hand side of the screen, you see the original enzyme replacement therapies, such as in the Pompe disease program, where you can actually give a functional version of the enzyme back to the patient. And all the way to the right is, instead of actually doing something to the enzyme, you can actually decrease the substrate burden, such as decreasing glycogen accumulation within the cells, and thus change the outcomes of the patient. Many of these delivery mechanisms suffered from not having enough transduction efficiency. We still had difficulty delivering our payload to our target tissue, such as muscle. And I would say that in the last few years, we've actually come up with multiple methods of overcoming that issue, and then also expanding our target tissue, our target organ, beyond simply muscle. This diagram actually shows the various different platforms that we have been utilizing in the last few years. On the left are the cell-penetrating peptides, including a linearized peptide that is conjugated to an ASO or a PMO, as well as a circularized peptide that is conjugated to a PMO. And on the right side of the screen, you'll see antibody oligonucleotide conjugates, including an entire antibody, a monoclonal antibody, or also known as a mAb, or a fragment of an antibody all the way to the right, known as a Fab, fragment antibody, which can be linked to an oligonucleotide or even a biologic such as an enzyme through a mechanism of fusion. So let's now talk about the FORCE platform, which is what Dyne uses in terms of its delivery mechanism. FORCE stands for Fab oligonucleotide RNA conjugate, with the E ending conjugate being the E that actually corresponds to force. Somebody in the branding department gets a gold star. And and force is a unit of, dyne is a unit of force, so it's rather clever. So the FORCE platform utilizes a fragment of an antibody. And specifically, it is the variable region of the antibody that is utilized for the FORCE platform, and that variable region allows specificity in terms of targeting the transferrin receptor. And the variable region also, the fragment antibody is then linked using a linker molecule, and then is subsequently conjugated to a payload. The payload can be anything from an ASO, it could be an siRNA, for instance, and on the flip side, it can also be conjugated to a biologic, such as an enzyme. And in terms of comparing the fragment antibody to a monoclonal antibody, a mAb, is that there's an obvious size difference, with the Fab being about 1/3 the size of a mAb. And we all know, and it has actually been well published, and even for the FORCE platform, the smaller the peptide, the easier the cell penetration. Other major differences include that the fact that the Fc domain, the constant domain, is not utilized for the FORCE platform. And harking back to our immunology days, the constant domain is responsible for fundamental immunogenicity, everything from cell-mediated phagocytosis to complement activation. And as a result, there's a possibility that we have less of the immunogenicity as a side effect compared to the mAb platforms. This diagram nicely represents for you what happens once you deliver the FORCE platform intravenously. It enters the circulatory system, it arrives at various tissue types at the cell membrane, where it binds the transferrin receptor. Once the transferrin receptor is bound, it then is subsequently forms an endosome and is internalized. Subsequently, the linker molecule is cleaved, thus releasing the antisense oligonucleotide or other payload, allowing that to escape out into the cytoplasm or even into the nucleus, and thus mediate its final effect. Now, the recycling rate of the transferrin receptor back to the cell surface membrane is fundamentally different when you compare the mAb to the Fab, with the Fab having a half-life of several hours versus the mAb having a half-life of approximately 3 weeks. And that thus allows the transferrin receptor to be present back again on the cell surface membrane, and thus allowing it to do its normal homeostatic function that's involved in hematopoiesis. And then also the transferrin receptor, it is expressed in multiple tissues, including tissues that we're very interested in neuromuscular disease. It's expressed in skeletal muscles, smooth muscles, and cardiac cells, as well as certain regions of the central nervous system. The diagram on the left actually shows you that the transferrin receptor is expressed on the blood-brain barrier. And once it enters the blood, once the transferrin, the FORCE platform with its payload enters the blood, it can then subsequently bind the transferrin receptor, undergo endocytosis, crosses the blood-brain barrier through transcytosis, and thus delivers its payload to the other side and enters the central nervous system, where it has the opportunity to be in contact with neurons and glial cells, and thus be taken up by central nervous system tissues. As a proof of concept, the picture on the right actually demonstrates that when given the naked ASO without the FORCE transferrin receptor platform, you can see that in the cortex or even the deep tissues in this non-human primate, that there's no uptake of the naked ASO, hence why it's dark. Well, compare that to using the FORCE platform, using a conjugate that is not what's actually used for the IP for myotonic dystrophy, You can see that there is uptake, hence the bright spots, even outlining the border of the cortex, as well as the deep nuclear structures of the central nervous system, giving us some initial proof of concept that this drug can actually potentially deliver its payload to the central nervous system. So in summary, the FORCE platform does actually overcome previous limitations in terms of having better transduction efficiency. It also targets the tissues that we are fundamentally interested in, besides muscle, including the central nervous system, as well as diaphragm in particular, and even cardiac and smooth muscles. And now I invite Dr. Kevin Flanagan to talk about the DMD program.
Dr. Lilliker. So hi everybody, I'm James Lilliker. I'm a neurologist working in Manchester in the UK, and it's my pleasure today to talk to you about the FORCE platform. But we're changing gear here now. We're talking about myotonic dystrophy type 1 and the ACHIEVE trial. So I thought I knew how to do this until I stood right here, but I think it must be this big green button. Here we go. So myotonic dystrophy type 1, it's a spliceopathy, and this is perhaps a different way of thinking about this disease. It's a potentially devastating disease. There's no effective disease-modifying therapies. And this expansion repeat, this CTG repeat in the DMPK gene, leads to RNA which contains a CUG repeat which forms nuclear hairpin loops which sequester NBNL. Now NBNL normally regulates splicing, so without it, with this NBNL which is degraded, splicing becomes misregulated across multiple genes and across multiple tissues. So myotonic dystrophy isn't really a myopathy as such. Of course there's muscle involvement, but it's a multi-system disease which involves many systems. You'll see here on this slide that some of the systems affected include the central nervous system, and indeed many of my patients have very significant CNS manifestations, including fatigue and excessive daytime somnolence. You'll see as well the respiratory manifestations here, with some patients requiring non-invasive ventilation, and importantly the cardiac manifestations of the disease, with many patients developing cardiac conduction defects and needing a pacemaker. And we spend a lot of our time in clinics trying to screen for early signs of these changes. So what's clear here is that if we're going to have a therapy for this condition, there's no point just targeting, say, myotonia. We need something that penetrates all of these tissues, skeletal muscle, cardiac muscle, smooth muscle, but also the central nervous system. So DYME-101, it utilizes the FORCE platform, as Samindra beautifully explained. It's a conjugate molecule. There's an FAB, a linker, and then an ASO, and that's delivered via the transferrin receptor into the nucleus. The ASO binds to these hairpin loops, and maybe I can, oh yes, yeah, I can get this working here, and it releases this sequestered NBNL, and then splicing is corrected. And what you see quite early is the effects on the myotonia, which are then followed by these broader functional improvements, and hopefully I'll convince you of this with some of the data that I'll show from the 6-month outcomes from the ACHIEVE trial. So first, some preclinical work from animal models. On the left, you can see target engagement in the heart, in the diaphragm, tibialis anterior and gastrocnemius, with DMPK knockdown there, quite significant values. In this panel here on the right, you can see the mutant DMPK foci area reduction, so that's these pink little blobs. You see here with the vehicle, the pink blobs are quite conspicuous, with the FORCE platform, much fewer. And then in the brain, and this is using a surrogate conjugate similar to DYME-101, again, these pink blobs becoming much less when the FORCE platform is utilized. So what we're seeing there is that broad tissue distribution and target engagement. So the DYME-101 ACHIEVE trial, this was a multiple, or it's an ongoing trial, a multiple ascending dose design across 5 different dosing cohorts, which is now fully enrolled. It was designed as a potentially registrational study, and indeed Dyne have selected the 6.8 milligram per kilogram dose given every 8 weeks as a registrational dose for an expansion cohort, which I'll describe on the next trial, the next slide. Patients given those lower doses were given the opportunity to increase the dose to the maximum tolerated dose in the open label extension and then long-term extension. The primary endpoint, of course, is around safety and tolerability, but there are additional secondary endpoints, importantly around splicing, but also multiple assessments of muscle strength and function, and importantly, patient-reported outcomes, including the MD high. So here's more about the registrational expansion cohort. So this will recruit up to 48 participants, randomized in a 3-to-1 ratio between DIAM-101 at that 6.8 mg per kg dose given every 8 weeks and placebo. The primary outcome here is going to change, and it's going to look at splicing change from baseline at 3 months, and I'll describe this to you later on, this CASI score and what that means. And then there'll be secondary endpoints at 6 months to do with muscle strength and function and patient-reported outcome measures. And the plan is to have full enrollment of that study, this expansion cohort, by mid-2025. So what I'm going to present to you today is some 6 months data from the ACHIEVE trial, from the 6.8 milligram per kilogram cohort, with that dose given every 8 weeks. You'll see in this column here a pooled placebo cohort versus the treated cohort here. You'll see that the characteristics between those two groups are pretty matched. There's a few small differences. The MD high here slightly higher in the treated cohort, and the time to complete the 10-meter walk run test and the 5 times sit to stand test slightly longer, so perhaps slightly more severely affected patients in that treated group. So in terms of the primary outcome here, safety and tolerability. So overall, there's been a favorable safety profile demonstrated in ACHIEVE across all of the different dosing cohorts. And this slide represents 855 doses administered over 72 patient years of follow-up. There have been several adverse events, but they've mainly been mild and moderate in severity. There have been 6 serious adverse events, but they've been felt not to be related to the study drug, and they're listed here. There have been abnormalities in liver function tests in a minority of participants, but it has been difficult to disentangle that from the quite routine abnormalities that we see in liver function tests in patients with myotonic dystrophy type 1 anyway. What has been clear is that there's been no significant effects on the synthetic liver function, so the bilirubin and the coagulation, which I think is quite important to see. And also there have been no participants with persistent anemia or thrombocytopenia, again providing some reassurance. So now we're going to talk about CASI, and this is to do with the splicing index and how we quantify missplicing. So CASI is the Composite Alternative Splicing Index, and what it does is it looks at the RNA splicing across 22 different genes which have been selected because of their relationship with myotonic dystrophy. So what this does is look at those RNA transcripts and looks at the fractional inclusions of different exons across those genes, standardized against some normal healthy controls, and then producing a score between 0 and 1. And 0 would represent an unaffected healthy individual, whereas 1 would be a most severely affected individual with DM1. So some exons are supposed to be spliced in, others are supposed to be spliced out. This is regulated via MBNL. In this cartoon depiction here, you can see an exon which is supposed to be spliced out, but a significant proportion of these reads are left spliced in, and you can see that this would contribute to an increased CASI score in this particular individual. So what this does is really characterize the residual MBNL expression. There's quite a bit of natural history data around this that's been accumulated, and this is some data from the MD1 study. And what we can see is that the CASI score changes quite rapidly over time. So here between baseline and 3 months, you can see a significant increase in the CASI. So over time, and time courses that are easily measurable, you can see the CASI deteriorating. You can see that splicing index getting worse. Moreover, the splicing index at baseline correlates strongly with functional assessments at a later time point. So here in these graphs on the right, this is 3 months later, and you're seeing strong correlation with their myotonia and functional measures, so 10-meter walk run, and some strength tests here. And what's really important here is that these correlations are actually stronger at that later time point as compared to timed matched assessments. And it gives a suggestion that the CASI has some prognostic implications and can give you the power to predict what might happen in the future, and therefore the potential response to a therapeutic intervention. So looking at target engagement in patients given DIAM-101 at that 6.8 mg per kg dose every 8 weeks, you can see robust DMPK knockdown in the treated participants, and that correlates with robust splicing correction and a CASI improvement of 25%. This translates into early and sustained and deepening improvements in their myotonia. You can see the treated cohort in this light blue line here, and a total of a 38% reduction in myotonia as measured by the video hand opening time there at 6 months. You'll see that in the placebo cohort, that line's fairly stable, or perhaps they're slightly worse over that 6-month period. Moving then to muscle strength, again you can see early improvements in the treated cohort, culminating at 6 months with over 10% improvement in their muscle strength. And this is the total QMT score, which measures 6 different muscle groups. Again, the placebo group deteriorate over that 6-month period. Some measures now of muscle function. So on the left, the 10-meter timed walk test. Again, the grey placebo group getting worse over that period, but the treated cohort with DYNE-101 showing improvements, and at 6 months there's a 7.2% improvement in the 10-meter walk run time. On the right, the 5 times sit to stand again, improvements which are robust and deepening over that 6-month period, an improvement as compared to baseline and as compared to the placebo group. And this measure, I think, is quite important because it's a combination of, say, strength, balance, and stamina as well.Going back to CASI and how the CASI might be used as a predictive biomarker of functional improvements at a later date. So what we're seeing here in these 4 graphs, and there's depictions of myotonia, with the video hand opening time, strength, and some functional assessments, is that as the CASI change from baseline at 3 months, the CASI change from baseline at 3 months correlates with those functional assessments at 6 months, and you'll see that there's quite robust correlations there across those different domains. Moving now to other important areas, so the MD-high, this is a patient-reported outcome measure that looks at 17 different domains of health and disease severity in people with myotonic dystrophy. You'll see at the 6 months time point here, there's a really robust improvement in the MD-high total score with a 44% improvement in the treated cohort compared to a slight worsening in the placebo cohort. What's important, I think, about the MD-high is it includes several domains related to central nervous system function. And if we look at those subscores, and here we have cognitive impairment, sleep, fatigue, communication, emotional issues and pain, there's improvements there across the board as compared to baseline and as compared to placebo. So this slide is a nice summary, and I think what it demonstrates is that taken together here, there's clinically meaningful improvements in response to DYNE-101 at that potentially registrational dose. That 25% improvement in the CASI at 3 months translates into meaningful functional improvements at 6 months in myotonia, strength, functional measures, and the patient-reported outcome measure MD-high, which includes those cognitive domains mentioned. So in summary, DYNE-101 is designed to target the mutant nuclear DMPK RNA and to correct the underlying cause of the disease, that spliceopathy and the missplicing that's occurring, and it's designed to tackle those multi-system manifestations across the different organ systems. There's broad distribution into the different systems as described, including the central nervous system. The safety profile, importantly, has been favorable to date. And what we've been able to show from the achieve portion and the multiple ascending dose portion is that 6.8 milligram per kilogram dose at the 8-weekly dosing interval has shown functional benefits at 6 months, and that dose has been selected as the registrational dose going forwards. I think that's me. Thank you.